Knowing I'm not going to be able to match any of the eloquence of Dr. Walton, I'm instead going to take a different tack, and I'm a lawyer, so I'm going to be a bit salty, so just wait for it. I think many people talk about global health governance the way adolescent boys talk about having sex. They say, everybody, they say, they are always doing it. We're definitely doing it. Some of them boast that they're doing it very well. Many are not quite sure what it actually is. And in fact, even when they are doing quote unquote it, not all of their partners agree that they are doing it in a way that they would like. All kidding aside, when it comes to financing of global health, it's hard to find a pricklier topic. On the one hand, the best and most innovative ideas you can find out in the world will die on the vine without the funding to make them a reality. On the other hand, to borrow a phrase from the film All the President's Men, we have to quote unquote follow the money. With finance comes the risk of influence, co-option, maybe even coercion. How do we thread the needle from innovative funding models that promote accountability and distributive justice, but don't change our core values? That's an incredibly tough set of questions, and luckily, I don't have to answer them. These people do. And luckily, we are surrounded by a panel of experts that I now get to introduce. So joining virtually, we've got Dr. Jayati Ghosh, a professor of economics at the University of Massachusetts Amherst. And in person, we're able to welcome Dr. David McCoy, the Evidence to Policy Research Lead at the United Nations University's International Institute for Global Health, Dr. Gregg Gonsalves, Associate Professor at Yale School of Public Health and co-director of the Health Justice Partnership, and lastly, our moderator, Dr. Alicia Yamin, lecturer on law and senior fellow at the Petrie-Flom Center at Harvard Law School, senior advisor on human rights and health policy at Partners in Health, an adjunct senior lecturer on health policy and management at the Harvard THN School of Public Health, and my teacher on these and many other issues for more than 20 years. I now turn it over to the panel.
Thank you so much, Glenn. And I also want to thank Louise Ivers and everybody on the team at the Harvard Global Health Institute for including this panel in this great event, and also for including it early on in the event, because the issues that we're going to be talking about in terms of financing and governance really affect everything else that we're going to be talking about throughout the day, whether it's climate crisis, whether, as we just heard from Dr. Walton, control of infectious diseases and drug resistance, pandemic preparedness and response. Everything that we will be talking about in some way touches on health financing and governance. I want to set the stage for the real discussion we're going to have. It's not going to be a series of long presentations. There are, I think, increasing, and we heard this in Dr. Walton's talk, there's more recognition now after the debacle of vaccine inequity during COVID of problems in global health governance and financing. But actually, these issues go way back. And so we're going to set the stage a little bit in terms of history before we then look forward as to where we go next. Now, there are many ways to start this history, and I think where you start reveals your ethical commitments. We could start with the founding of the WHO 75 years ago. We could start in the late 70s, early 80s when neoliberalism began to absolutely sweep the world and had an enormous effect on governance and global health governance. We could start about 25 years ago in the late 1990s when there was waning foreign aid. As in 2000, the Global Compact was announced, and there was a new framework for engagement of non-state actors with the WHO that was overlaid on ongoing trade liberalization. The WTO had just been established in 1995, increasing financialization, accumulating debt crises that, of course, in 2008, after the financial crisis, absolutely exponentially exploded with austerity being imposed all over the world, which affected the financing and governance of health systems. We also had increasing, exacerbated by financialization, increasing illicit financial transfers and multinational tax evasion. So these are the issues. We're not just going to look at a resource envelope that is fixed, that global north countries can decide in a charitable, obsolete way to give to countries in the global south that then have to make really horrific trade-offs, but we're also going to look at where the money is sucked out of the global south, whether through extractivist labor and other policies, whether through intellectual property, which is a massive wealth transfer from the south to the north, whether through tax evasion and debt payments. And this view of global financing and governance is not something that looks at these as technical challenges, right? Not just mobilizing more money for a certain fund, not just dealing with coordination problems, as we saw that were evident during the pandemic with the WHO, but really looking at them as more structural, more political questions of political economy. And I want to sort of now, with that framing, throw it open and let each of our guests kind of choose their entry points to how we analyze this problem. And hopefully, toward the end, we will be able to move toward where can we make changes concretely. So Jayati, can I turn to you first?
Yeah, thank you so much, Alicia, for inviting me to be part of this really thoughtful discussion. I really found the keynote speech also particularly thoughtful. But I'm going to focus specifically on finance, not all the hugely important intellectual property rights issues that you've just briefly mentioned, but particularly in terms of both public and private finance. And first, I want to say that, both the quantity and the quality of finance are important. And that's something we often forget. We talk really only about the quantity. And yet we find that a lot of the finance that's available, even in the public domain, is very short-term oriented. It's not patient finance. It's not looking over the medium term, forget the longer term. And it's not really enabling the last mile kinds of delivery to those in need in a way that Dr. Walton was also describing. In that context, I do believe that our current global financial architecture it's not just not fit for purpose, it's actually antithetical, it's counterproductive for public health purposes. And there are several aspects to this. There is the aspect of debt that you have already mentioned. We know that more than half of the world's population now lives in countries where debt payments exceed the expenditure on health and education put together. We also know that many other countries that are not defined as being in debt stress, nonetheless are experiencing significant increases in their debt repayment through no fault of their own, but simply because the minute the US raises its interest rates, global interest rates go up, but the spreads on developing country debt go up even more. So many poor countries are now facing spreads of 11 percentage points above the US Fed rate, which is unbelievable and is deeply unjust because it actually massively increases the debt repayment burden with no actual increase in the debt levels. The second issue is that of the volatile capital flows. And that's because, again, we've had all countries in the world, even low-income countries, least developed countries, being encouraged to open up their capital accounts in a way that has rendered them very vulnerable to private flows of capital in and out. We know that public flows, aid flows, for example, have dwindled to almost nothing other than a little bit from China now. Everything else is really private, and this is hugely dependent on perception. And those perceptions are dramatically affected by the macroeconomic policies of the advanced countries. So if you like the sort of colonial pattern, but basically large parts of the global majority are affected by macroeconomic policies over which they have zero control, and which then cause capital to move out in a way that, once again, has huge domestic impact financially, but also fiscal impact. And these volatile capital flows in turn create a huge pressure on public finance in terms of pushing for constant fiscal consolidation. Countries that have fiscal deficits are constantly trying to reduce those. Countries that have fiscal surpluses are trying to increase them. It's bizarre but true that it's happening all around us. Everybody's obsessed with generating primary surpluses on their budget. And this, of course, means austerity. It means cuts in public health. It means cuts in nutrition spending. It means a cut in a whole range of things. We have no conditions on the subsidies that we provide private investment. This was really evident during the COVID-19 pandemic when big companies, big pharma, basically got a free pass to get the benefit of subsidies and patents provided by the public sector, and then could charge what they like and restrict knowledge in whichever way they liked. We do not have adequate control on financial flows in terms of the impact on global food markets, because this impacts nutrition as well. And as a result of these major spikes in commodity markets and food and fuel markets, the prices go up in developing countries. They don't come down when the global price comes down, because meanwhile the currencies depreciate. And that too is adding to the broader sort of public health issue, because poor nutrition, as we know, impacts on health. And finally, the illicit financial flows, and particularly a very outdated taxation system that doesn't recognize the existence of multinational companies, doesn't recognize that they can shift their profits to low-tax jurisdictions, does not enable the taxation of wealth because we don't have adequate knowledge about who has stashed their wealth in which location. All of these require global cooperation to fix. And these are things that really constrain the ability of many governments to actually put in the required long-term patient funding for health that is so essential.
So Jayati,
I'm done, Alicia.
Okay, great. Thank you. Thanks for that great overview and portrait of many of the challenges we face. David, should I turn to you first to introduce your set of kind of points and Andrew?
Well, I'm going to build on what you and Jayati have said, which is really to emphasize the structural political economy determinants, not just of health, but these are determinants of social and economic inequalities right across the world. And this, of course, touches on the work of the Commission on the Social Determinants of Health, the work of Paul Farmer, talking about structural violence, talking about these being the fundamental core determinants of health inequalities. We can also think about the UNICEF conceptual framework, which talks about the basic causes of differentials in child mortality being related to how resources are distributed across society. So I think when we're talking about global health, when we're talking about global finance, global governance, we really need to be, we're fundamentally talking about politics that shapes systems that serve the few at the expense of the many, that currently also serve current generations at the expense of future generations when you think about global warming. We also have systems and structures that, to my mind, also seem to serve the worst aspects of humanity as opposed to encouraging the best aspects of us as human beings. We see vast amounts of profiteering. We saw that in COVID. Obscene amounts of profiteering in the midst of a global emergency. And there is perhaps no better demonstration of the fact that we live in a world of contemporary colonialism by the fact that we can have a room full of mostly men own as much wealth as the bottom half of the world's population. These are really mind-boggling, eye-watering concentrations of power and wealth that do not simply leave large segments of the world population impoverished, but this is also a political phenomenon in the way in which it is able to undermine democratic systems, a way it's able to undermine governance that would work for everyone. So I guess my point or what I'd like to really throw out for conversation is, what do we do about this? What does the global health community do about this? We are health professionals. We work in the health sector, but that health sector is located within a political and economic context that is highly inequitable, highly destructive. What is our role? And here, I think we need to be much more critical. We really need to throw a much more critical lens on the way the global health system itself is structured, the kinds of narratives that we put out, and the way in which we are interfacing with this wider political and economic system. And I'd like to suggest that we often do as much harm as we do good. Often in the process of thinking that we're doing good, we are inadvertently very often doing harm, often through the process of neglecting the social, political, and economic determinants of health, often through over-technologizing the challenges of disease and illness, and through that process, again, causing us to detract attention away from the politics, from the injustice of health inequalities. I think there are also forms of philanthropy, forms of charity, which are really designed to sustain power imbalances. And we need to look really, really honestly and truthfully at that. Because often these approaches are shrouded in a language of charity and doing good, but in actual fact, they either sustain and sometimes even worsen inequalities. And of course, as we saw with COVID, we need to also be thinking about the global health system as a space in which extractivism continues to occur. You know, we can talk about COVID-19 and the profiteering that occurred with the vaccines, but when you look at the way financialization is happening in health systems across the world, the way in which we are also using development finance to bring in private investment capital whose only objective is to create a profit, we see vast amounts of damage happening now to the already fragile health systems in low and middle income countries. And yet, all too often, we are looking still for further private investment capital without recognizing its destructive effects. And to some extent, I think this is people in global health thinking that this is a good way of filling in the financing gap. But I think there are also actors in global health that see this as a continued form and mechanism for exploitation and appropriation and profit making. So I'm just going to end there and say, let's by all means talk about the politics and the structural determinants of health, but let's look at how we interface with that and have an honest conversation about the good that we do, but also the harms that we inadvertently cause and sometimes deliberately so as well. Thanks.
So, Gregg, those are very provocative statements from David. I'm wondering whether you could talk to us either about COVID in particular or more broadly about how we got into designing systems that can be so counterproductive, and whether you agree.
So, first of all, thanks to Louise and the Global Health Institute for inviting me to be here. I think there's a lot of agreement among people on this panel, but I want to say that the topic of this panel is governance and financing, but I think it's a second-order problem, right? I want to suggest that if we think we just have the right institutions, we could fix things, is a gross error of reasoning in terms of history and in terms of the current sort of landscape of global health. The first-order problem for us, I think, is what political scientist Jessica Green, who does climate change and global warming, says is the existential politics of climate change. And we can change it here to the existential politics of global health. And she talks about it as whose way of life gets to survive, right? She talks about Exxon and Mobil and the Maldives, right? But we can talk about this in the same way, about whose way of life gets to survive. So I think we're all in agreement here that there are many people here who work on the technical aspects of global health in very, very, very specific detail. But what I think faces us in the end is not a technical problem, but a political one. And I think we really need to let the elephant in the room. I walk these streets like 30 years ago, in the midst of the AIDS crisis. And, I watched my friends die, and I watched a government that couldn't give a shit about them because of who they were. They were gay men, they were junkies, they were whores, right? I didn't think it could get worse. And then we saw the COVID pandemic. And a lot of my AIDS activist friends sort of came out of retirement, came out of the woodworks to fight for access to COVID vaccines. But the entire structure failed us. From COVAX to the WHO to the US government, at all levels, failed the world acutely. If you look at the excess death figures that have come out over the past few months, Uganda, Zambia, Chad, others have devastatingly excess deaths from the COVID pandemic, while many of us in this room are probably twice, thrice, quadruple vaccinated at least, right? So it's still happening, right? The pandemic treaty, forget about resource sharing, pathogen sharing. We have a sort of rump pandemic treaty that's set to be ratified, right? Moderna just closed its plant in Kenya because they said there's no interest in Africa in COVID vaccines. What I leave you with is a question, and I'm talking about our institutions, Yale, where I work, Harvard, where many of you work, is that what if our institutions are working as designed? Daron Acemoglu, who is at MIT, and James Robinson, who used to be here, wrote a book called Why Nations Fail about 10 years ago. And they said those who have power make choices. They make choices. They don't get it wrong by mistake or ignorance. They do it on purpose. And this leads us to another question. We all work in global health. And how are we going to look at the power structures that enable what David and Jayati and Alicia has talked about? What kind of incentives have we built to allow the actions that we've seen happen over and over again over the past 30, 40 years continue to happen? And how do we start to build into our own work, even if we're working on tuberculosis or HIV or mental health, how do we think about the political economy of health as integral to our work as academicians, as clinicians, and not as some sort of abstract topic for philosophers or political scientists or economists? What we want to try to do really is up against the structural constraints that are not getting better over time. And we're being asked to fight for crumbs from the table rather than talking about why we don't have a bigger pie and a world that's more fair and just.
Thanks very much. So I want to give the panelists an opportunity to ask each other questions or make comments before we move on.
Should I go, Alicia?
Sure, Jayati.
Yeah, no, I mean, I'm obviously there's huge agreement, I think, among all of us in terms of what we see as the problem. But I noticed that in the Q&A, there are already a set of questions about the way forward. And I just want to highlight, some attempted good news, let's put it that way. I think that there are movements in Africa, especially in response to the pandemic. I think the Africa CDC was particularly active in response to the pandemic, but also subsequently the attempts to actually localize production. The mRNA initiative, which the WHO did support, the Afrigen as the hub of this for production in different parts of Africa, the attempt to actually provide money from the African Development Bank to create much greater production within the region, which means the entire supply chain. And that's a huge ask for these countries. I think this, once again, this raises two kinds of issues. One is, of course, the financing issue, because it requires patient finance. And we already saw an example of inpatient finance when Moderna, which was supposed to open a facility in Kenya for the manufacture of COVID-19 vaccines, has just pulled out 3 days ago because they've decided that the market demand is not strong enough anymore for them to bother with it. So they had promised, I think, a $4 million investment. They brought it down to $2 million. Now it's zero. They're just pulling out. So we've seen what happens when you rely only on private delivery. We definitely have to go for the public delivery of this. So that's number one. But the second and really big issue here is the intellectual property issue, which relates to the broader concern about governance. Once again, Moderna filed a case against Afrigen for the misuse of its patents. Remember, half of these patents actually came from the US government, and the rest of it was entirely funded by the subsidy that they received for the production. But nonetheless, the compulsory licensing options available in the TRIPS agreement do not protect governments fully, because you have to take them from company to company and for each individual patent. And for the mRNA vaccines, there are about 64 patents, I think, involved, for example. So we really have to think of another way of getting around this. And we keep clamoring for some kind of a lifting of these, but we are going to see more and more of these. We have to think of a way of getting around the problem so that any attempts to localize production or to decolonize the production don't come up against this wall of intellectual property rights. And that, it's a tough one, but I'm just wondering whether we can think of a way in which coalitions of countries can actually come together and sidestep this and say, yeah, we'll take on the case and we will fight that case and maybe somehow embarrass rich country governments. And I will name US, UK, Switzerland, France, Germany as very, very major governments from supporting the multinational companies that do this obscene thing.
Thanks, Jayati. I want to underscore one comment you made about how compulsory licensing is not the solution, which many of the wealthy countries, when they were denying the TRIPS waiver, said, oh, no, it's no problem because we have compulsory licensing. So the idea that a poor country would go ahead when there's 64 or sometimes more patents involved in one single vaccine and have to risk the litigation challenge to all of those things is just unbelievably disingenuous on the part of those negotiating governments.
I mean, we're also talking about the structure of governance and financing, and we'd like to abstract it to the Global Fund, to the WHO, to World Bank. I bring you greetings from New Haven. We had our Yale Global Health Institute symposium last week, and Madhu Pai was here from McGill. And everybody in the audience had their mouths open. He talked about the governance and financing of global health. Who runs major institutions? Who runs the journals? Who gets the grants? And they are predominantly 80%, 90% white men, right? I'll send you his presentation, it's online, but the entire structure of our field is inequitable and set up to fail, right? It's built out to enforce the status quo of power and resource flows, right? I had no idea any of this was true until Madhu put these slides up in great detail about all our institutions. Many of them we work for, many of them we depend on for funding. And so we need to address these structures of finance and governance within our own world and our own domains, not just these bilateral and multinational institutions.
David, did you want to come in there on how we address our institutions?
I mean, there's no question that global health is dominated by a certain segment of the wider global health community. But I wanted really also to pick up on Jayati's comment about it's not just about the quantum of financing, it's also about the quality. That there's an incredibly important distinction between public financing, public interest financing, and private financing, particularly private financing that is designed to generate a surplus or generate a profit. And this, what we have now is a world where there is a huge imbalance between public finance and private finance. And this really, I think, forces us to look at the issue of tax much, much more importantly than we have done. I wrote about 10 years ago an article about tax being the most neglected public health instrument that we have. Tax is not just about generating revenue, it's also about generating good governance. And there's a lot of work that's been done showing a correlation between percentage of GDP captured as public revenue and good governance. Tax is also fundamentally about redistribution. So it has a mechanism by which we can address the socioeconomic inequalities that underpin health inequalities. And tax is also about regulation and repricing and kind of correcting market failures. So there's a whole variety. It's a super social policy, as Alex Cobham from Tax Justice Network keeps saying, super social policy. And yet what we have across the world is a broken tax system at the global level, at the international level, but also at the level of countries. We have a glimmer of hope at the moment, thanks to the African governments who are pushing ahead with an international tax convention, an international tax treaty. And if there's one thing I would ask the global health community to do, including ministers of health from every single country, it is to put their weight behind this effort to fix this broken tax system, which is the root cause of so many other dysfunctional problems that we have in countries. Jayati has probably got more to say on this.
So,
Yeah, David, I am so delighted you raised that point. Sorry, can I just come in very, very quickly?
Of course.
I think I really want to emphasize and underline what David said. It is critically important because at the moment, the whole world is losing anywhere between $260 to $570 billion, depending on which estimate you take, in tax revenues that should be coming on the basis of existing tax rates, simply because of the ability of governments to move this money around. Of multinational corporations to move this money around to low tax jurisdictions. There is a way of dealing with that. It's actually quite easy. You tax every global corporation as one company, and every country taxes its share of the global profits according to a formula based on sales and employment. It's really actually, when you think about it, conceptually very simple. It is the policy that the US adopts vis-a-vis its own states. So it's something that could be implemented, but then the outcome we got in the OECD was extremely, shall we say, favorable. It was welcomed by Apple, Amazon, etc. So you can imagine. It was favorable to the companies rather than to governments. And it was also within that more favorable to rich country governments than to the rest of the world, which is why the Africa Group pushed so hard to get it into the UN. It's not a done deal. Let's be frank. There is still a lot of resistance by developed country governments, which is why it's particularly important for citizens of rich country governments to demand that, because it's in everybody's interest. It's in people's interests. It's in the ordinary people's interest. It's only companies that are badly affected. This kind of the UN Tax Convention that takes into account all of these things, that takes into account country by country reporting of wealth, which would enable wealth taxation and so on. This would actually be a huge step that would benefit everybody, taxpayers all over the world and public finances all over the world. But as long as it's being resisted by the rich country governments, it will be harder to push through. So it's really important for much more public mobilization in the rich countries as well. It's not just between countries. It's really big pharma, big corporations versus everybody else, I think. And so I really just want to emphasize what David just said.
thanks very much for adding that, Jayati. So I think we'll take some questions from the audience, and then maybe Olivia can give us some more of the questions from online. Diane?
I've already asked one question, but if there's no one else, I guess I'd like you to maybe narrow in a little bit on the big funders in global health at the moment, the Global Fund and Gavi, okay? And tell me what you think of those structures. They've made, they have changed the conversation over the past 15 or 20 years that they've been in existence. And I wonder what you see going forward in terms of, because this, for many countries, is a major source of funds for the diseases that I worry about. So malaria, but TB and HIV. But it does disproportionately focus on those. So I just want your reflections on that.
Gregg, maybe turn to you.
So, I remember being with Jim Kim at a WHO meeting when we were pushing for antiretroviral therapy along with our colleagues from Brazil and South Africa and Thailand and others who were saying, you have the pills, why don't we have the pills? And I thought of it as a great success, right? And to come 20 years later, I started to think of it as it was a great concession, right? But we still have millions of people without access to HIV therapy. And on a limited budget, who gets prioritized with the funds we do have? It's not MSM, it's not drug users, it's not sex workers, right? You get special treatment because whatever government prioritizes is what happens, right? And so we're in a situation where we fight for crumbs from the table. It's concessionary. It's a charitable model. I remember arguing with Paul when he came to New Haven once, saying charity is not a substitute for social justice, right? And what we were in this charitable mode, waiting for the next handout from G7 donors. Meanwhile, we have an extractive economic system which is pulling resources out of countries, using the tax code and other things, where we can enhance the pie, we can change these structures to be more equitable across the board, not just for TB, malaria, and HIV, for primary health care, for all of the things that we care about. But right now we're in this sort of, we're just very happy that if we get another $1 billion for this, or another $1 billion for that, and we never ask questions about, maybe it could be different than it is today, right? And I'm an old HIV activist. I should be like, yay, 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 I'm so happy for PEPFAR, I'm so happy for the Global Fund. I think the fundamentals now are so terrible and rotten that we don't have a future for global health unless we deal with these fundamentals now. That means all of us, people, there are many HIV, TB researchers in this room, it's part of our job too. It's not just for David and Jayati and Alicia, it's for all of us to do this.
David, did you want to add?
Yeah, I should first of all admit that I've been a critic of those global funds pretty much from the beginning, because I saw them really as a sticking plaster over these more fundamental structural problems. And I saw them as, I worked in Africa for 10 years, and I saw the damage they did to health systems through their vertical programming. So for me, looking at them, it's very much dependent on what lens you look at. If you're looking at the lens of lives saved from particular diseases, they look like an amazing success. Although I will say that the claims that are made about lives saved are often exaggerated, and that much of those lives saved that are attributed to the Global Fund or Gavi are in fact also lives saved by public financing, by other sources. But if you look at the bigger picture, I think, which is what Gregg was saying, they have not addressed the more fundamental problems. I don't think they are yet, David, despite the best intentions to strengthen health systems, I don't think they are actually doing that adequately enough. But it's also very difficult for them to do that, given the wider political and economic context. So again, it's a sticking plaster. And sticking plasters can be useful, but if we only look at the sticking plaster and we don't look at more transformative forms of, therapy for the structural problems, that's all they'll ever be. And we're losing ground now, especially with the problems that Jayati was alluding to with the rise in interest rates and the increasing debt burden. We're going to be seeing reversals in the gains that have been made over the last 10, 15 years. And I also just think that, coming back to the point I was making earlier about how we tend to depoliticize global health, I think a lot of the rhetoric around saving lives has been used, I think, to detract attention away from, exactly what Gregg was saying. We're saving lives here, but we're extracting vast amounts of wealth from Africa here.
And elsewhere in the world, Latin America, yes. Yes.
Yeah, I just want to add another contradiction in these global funds. And this was something that was highlighted by Donald Kabaruka, who was the chair of the Global Fund. And he said, basically they're hugely underfunded. And the reason they're hugely underfunded is because the governance is more democratic. And so the G7 doesn't like it. The rich countries will not put money into funds where they cannot control the decisions. Rich country governments, I mean. And that's an unfortunate reality. And I think we have to recognize that all of these global funds ultimately are strongly controlled by interests in the global north. And a lot of the times, these interests are also subject to conflicts of interest. Let's not kid ourselves. Gavi, for example, right? I mean, I don't know whether the G word can be mentioned here in terms of the Gates Foundation and so on. But, there are definite conflicts of interest. So there is a fundamental contradiction between, saying something is underfunded and therefore it is ultimately just a sticking plaster, it will not be able to do very much and so on. And having a more democratic kind of an organization, which would provide the money as we would like. For example, Alicia, you and I have been involved in the global public investment discussion, and we would like a more democratic thing. The trouble is that then rich country governments are not going to put money into that. So we have to think of ways around swimming around these big fish, if you like, in terms of both financing and enabling a transformation that would actually work. I mean, the power structures are not going to give way very easily. So we have to think of ways of chipping at the edges or moving around those. certainly recognizing that they exist. But the funds in themselves, and this is not just true of the health funds, the same is true, the pandemic fund is exactly the same thing, hugely underfunded. The RST, the Resilience and Sustainability Fund of the IMF, I mean, all of them get a fraction of what they want to give. And even that fraction then ends up being controlled by certain interests. So there is a problem with these. And yes, they do have, individual successes. That's you can't. It cannot be that you're spending money without getting anything. But that's not enough in terms of a resolution of this issue.
That's great, Jayati. Thank you. So, while we as individuals may yield power to be better accompagnateurs, structurally, the powers that be are not going to yield power. So yes.
I'm Ken Friedberg from Mass General, and I was going to ask a question that I thought was an optimistic one until Dr. Gonsalves just smashed it down. So the optimistic question was, what can we learn from the HIV epidemic about this, which I would say has been a stunning success, even though we just heard, Gregg, about PEPFAR is a failure, the Global Fund is a failure, and I think a lot of the institutions that we're talking about are failures. But I was a medical student and resident in the 80s and watched everyone die. Everyone died. And then in 1996, treatment became available. So if you went to the CVS right there in 1996 and bought a year's worth of AZT, 3TC, and Dinavir, $28,000 in the United States, if you paid for it. And I love cost effectiveness. Dr. Walton used the word 4 times negatively. Paul Farmer and I argued. Paul hated cost effectiveness, because you couldn't pay $28,000 per person in Haiti, and he hated it. But it's about value, and it's about what you could do with $28,000 in Haiti. Here, that was great value. And now those same drugs, better drugs, CVS, will cost you $58,000 for 1 year. But that went to $2,000 in South Africa, then $700, then $150, and last week in Chennai, generic 1 year of therapy, as good as what you can get, $55. So these drugs are available to millions of people. I won't use the word save lives. No one's life ever gets saved, really. It gets extended year after year, which is our whole goal in healthcare and global health. So what was done in HIV is, we can't use the word unprecedented anymore, but it was unbelievable. And so how can we make sure the malaria vaccine has some kind of tiered pricing? Now, maybe it is about the TRIPS agreements and all of that, but if we can get drugs, and when there's a TB vaccine that Dr. Holmes is working on, and the Gates Foundation and others, that vaccine has to be available worldwide at prices so that somebody makes some money, but people who get it, who need it, get it. And so we're not going to solve all of these, but the question is, can we learn something from what I would say is unbelievable success? So,
Okay, so thanks very much.
So look, I'm here alive because I took my ARVs this morning, right? I am not saying there's no difference between 1981 and 2024. I'm not saying that lives didn't get saved in Haiti and other places because of the introduction of ARVs or treatment for XDR-TB. The point is it's all relative, right? And that on a scale of what we could do, as opposed to what we're doing now, there's a vast gap. And the lesson of HIV is that you keep pushing, right? And we talk about the social determinants of health at public schools of public health. We need to think about the political determinants of health. And what we've been talking about here is all of that. And all of my friends who were AIDS activists in the 80s and the 90s and are new friends from the 2000s and the 2010s are starting to realize that you have to stitch this all together. The story that Jayati and David and Alicia and I are telling is really talking about what kept us from doing even more than we wanted to 20 years ago. What has kept us with underfunding in all the areas we care about and the resource flows coming out of countries more than that comes in from these international partners. So we had great successes. We can do better. We keep fighting, right? And we don't sit on our laurels and think like, gee, if we could get another $1 million for this, or Gates decided to turn a bit and do a piece of work in an area that we're interested in, we've reached success and we've reached the promised land. It's always going to be an iterative process over time. The point is that my appeal to many of my friends in this room is that come join us. I work on cost effectiveness. I do technical stuff in my day-to-day job. But the politics is important, and we have to engage, right? Global health is not just a technical issue. It's an existential politics about whose way of life gets to survive, right? And read Jessica Green's article on this in the Boston Review. You know, we are facing a calamity with climate change, right? And we can't do business as usual. What worked 40 years ago is not going to work tomorrow.
I cannot resist coming in on cost effectiveness, if I may.
No.
Okay, quickly, Jayati, and I think David too, and then there are more questions.
Okay, so no, just very quickly. You know, India was exporting the ARV cocktail at 3,500 rupees per person per year, way back at that time. Okay, that's about $50 per year. This is at the time when I think you were saying it cost, I forget how many $1,000 in the US. It was stopped because the US brought US pharma companies brought cases against all the countries that were importing it. The so-called TRIPS Declaration on Public Health in Doha was actually a way of reducing the possibility of that export because it brought down the conditions under which you could actually do the compulsory licensing. The subsequent agreement on parallel imports was another way of reducing those possibilities. So these legal things that happened in the WTO that were presented as big positive steps were actually negative steps, reducing the ability to provide universal access.
David wants to say one thing, and then we'll go to more questions.
I think Jayati said it. I mean, there were a lot of things that looked like great successes and great steps forward, particularly in the realm of intellectual property rights, the Doha Declaration, but which turned out not to be as successful as we initially thought they would be. But the one lesson I think we should take from HIV was the fundamental importance of social activism, of people being politically engaged with the problem. And in the case of intellectual property rights, it was also about civil society mobilizing hand in hand with governments to address the power of big pharma. And that was critical, particularly the role played by South Africa, I think.
Yes, here and then here. Maybe we'll take a couple of questions because we're...
Thank you. I'll try to be brief. So my name is Jessica Haber. I'm at the Mass General Center for Global Health. I'm a researcher, and I've been dabbling in the advocacy that you're talking about around reform for research funding. And when I've started to talk to people at NIH or thinking about U.S. government institutions that provide funding for research globally, I'm very, very quickly confronting the rebuttal that now's not a good time. And I'm wondering when there is a good time, and I think it's probably never, but I'd be curious what the panelists have to say. I mean, obviously there's an election coming up in the US, there are populist movements around the world, it's not just in the US. But as we're thinking about advocacy and how we can be strategic around some of these issues of promoting localization and different types of research funding, indirect cost rate, reform, that sort of thing, how do you suggest we manage the political climate?
So that's a great question, and I do want to take a couple because our time is going to run out. So,
thank you very much. I'm Richmond Ousu, a health economist at the University of Ghana School of Public Health. Mine is not a question, but a contribution. So on the comment about Global Fund, Ghana has been relying on Global Fund for HIV, TB, malaria. And a couple of years, we moved to lower middle income level. So donor support has been going down significantly. So planning about sustainability, these partners are thinking about moving these vertical funding to the National Health Insurance Scheme. Currently, that's probably the main financing system for Ghana. So what we see is that it's going to be good for sustainability purposes, but at the same time, the trade-off of the burden of the sustainability of the scheme itself is also something that is a big thing we are thinking about as a country. So there's that conflict of thinking long-term sustainability, but at the same time, how things will work. Yeah.
That's a great example. Thank you. Are there any other concise questions? Yes.
Yes, thank you. My name is Rocio Sáenz. I am from Costa Rica. I was thinking about your comments about the social determinants of health and the inequality. I think the COVID-19 show us as a global people and the country level and globally that we are really in an amazing place with the huge inequalities. As a global person here, we must to move and change the way that this structure are reproducing the inequalities, where the life of the people has a value. And I think this is my concern and my call, because we can do the same that we do before. We have to learn as a global society that we have to move it and go forward, not repeat the same mistakes and repeat like there is a people who has more value than others. And this is, for me, the most important, lesson learned for this panel. Thank you.
That's great. And many of us did think that the pandemic was going to be an inflection point where we would learn to do things differently, and that has not proved to be the case. Vikram, really quick question, and then just a minute reply, because we have very few minutes.
I just wanted to ask the panel, in following on from my colleague from Ghana's comment, it's the same in India. Almost every country that transitions from low to middle income, actually global funds pay almost no impact. All financing and decision making and priority setting is local. And I wonder to what extent is the very nature of this top-down financing got a runway to obsolescence, that ultimately every country will be free of decision making in the north on how they prioritize and structure and finance their healthcare system. Because certainly in India, nobody even thinks about global funding anymore because it makes no impact. It's got zero impact on how decisions are made. They may not be the right decisions, but they're certainly not being made outside the country.
And I turn to all of you and Jayati for responses on any of these. Research proposals going forward. Yes.
So a couple of things. Does anybody know who Frances Perkins is? She was ready. She saw the Triangle Shirtwaist Factory happen, right? And she started thinking about ways to fix labor regulations in the US. And when Franklin Delano Roosevelt said, I want you to be my Secretary of Labor, she said, I'm going to institute all these programs, and he said yes. So you need to be ready, right? It may not be the perfect time today, but you need to build towards that moment when you can get in the door and make structural changes. India may not rely on the Global Fund, but if you look at the pricing for drugs for hepatitis C and other drugs, middle-income countries get shafted, right? They don't get the concessionary tiered prices that we talk about. They often get shafted, right? So they are still embedded in these sort of economic policies that are being instituted through these health institutions, but in a just different way.
And private equity is going into India. Do you want to add something on India, Jayati?
No, I think Vikram got it right on India. I just want to say one thing about public financing. We need much more of it, and yes, taxation is essential for that. But also we have to make sure that when the public financing is oriented to what are called partnerships with the private sector, that we put in the conditions to make sure that the private sector doesn't get a free ride, doesn't actually just extract profits from the public subsidy. We've seen that all along, but especially during the pandemic. So basically a plea for governments everywhere, when they're getting into these subsidies and partnerships with private companies, they have to put in conditions that democratize access to knowledge and to the product.
David?
Maybe just respond to the political climate that we're living in. I used to give global health lectures, a kind of generic global health lecture about 15 years ago, my first slide was a picture of a glass that was half filled with water. And I would ask the audience, whether you think this glass is half full or half empty is possibly the most important global public health question. Because on the one hand, we had all these tremendous successes, this rise in global health financing, global fund, everything to do with reducing mortality. On the other hand, you could quite clearly see the impending environmental crisis, and you could see the problem of rising social inequalities that were happening across the world. We have impoverishment in the US, and we have massive wealth concentration happening also in African countries. So this problem of social inequalities is now coming back to bite us in the form of a democratic crisis that we're seeing again all around the world. So, when I look at that slide that I have of the glass half full or half empty, I kind of feel right now that the glass is 3/4 empty. And I feel we're in a really bad place. But at the same time, I think we as a global health community have a real opportunity, have a responsibility, and have a mandate to be able to try and fix these problems. They're huge, existential, complex problems, and there are no silver bullets. But we do need to be part of the solution and not to be continuing part of the problem.
So with that, I want to thank my incredible panelists, really a spectacular panel, and thank all of you for your questions. And finish quoting Paul Farmer, who has been quoted quite a lot already, also a beloved colleague and mentor and inspiration in my life, with something that echoes what Dr. Sainz said from Costa Rica, that he said the root of all of the problems in the world is that some lives have more significance than others. I'm paraphrasing a little. And I think that these are issues that shape whose lives, as Gregg has said repeatedly, whose lives are given significance, are invested with significance by our system. And the second quote I want to say, Paul was always battling against nihilism, against fatalism. And that's also, I think, a call to arms that all of us have given here about we in the global health community as leaders with the many layers of privilege that we walk through this world with can do something about this, can look beyond our immediate technical measurement challenge and look at how the system is operating to systematically injure and harm certain populations and advantage others. Thanks very much, and I'm really looking forward to the rest of the day.